Activist Coalition on TB Asia Pacific, Australian Global Health Alliance, Results Australia, and Stop TB. We wanted to welcome you to this roundtable discussion, and as you can see, we did our best to kind of create that roundtable in a physical sense as well as a metaphorical sense as well. So hope you appreciate the engineering efforts there. So basically today, over the next couple of hours, we wanted to have a little bit of a discussion looking very much at pandemic preparedness and health security through investments in tuberculosis. Coming fresh off the back of, or in the midst still, I suppose, of the pandemic on COVID-19, a lot of lessons have been learned, particularly at the country level and from countries in this region of Asia Pacific. Many of those lessons really show how investments in tuberculosis, in informal systems and in community systems, have supported countries to better respond to the COVID-19 pandemic. And with an eye on the future, it also shares a number of lessons that we can take on board to further strengthen health and community systems to be better prepared for future pandemics and to ensure broader health security as well. So today we will try to keep it informal, but we'll have some discussions, but then we very much invite everyone in the room to contribute, to engage. We have a few roving microphones, and so please just raise your hand and we look to engage you throughout. We'll also have some engagement through Facebook Live as well, because we have a superstar communications person helping us over there. So thank you, Annie, for leading on that. So to start, we'll have four parts of this agenda. The first part will, I guess, to provide a little bit of an overview and a snapshot looking at airborne pandemic preparedness, response, global health security, and the space of TB in that sort of discussion. Just before the second section, I've been advised that lunch will be available outside and you can grab it, and then just bring it back in. We keep it informal when you can keep the discussion going over lunch. We'll then have 5 country partners from around the region, including Papua New Guinea, India, Cambodia, Philippines, and Indonesia, sharing some of their reflections and their experiences from a community and civil society perspective about how investments in the TB response also have supported COVID-19 efforts on the ground, and they'll provide a few examples of that. Then we would be joined by Peter Sands and Lady Roz from the Global Fund in a session that will be led by the Australian Global Health Alliance, looking very much at the importance of financing TB in the context of PPR, and in particular the need for a fully funded global fund as we embark on a replenishment of the global fund this year. To conclude, we'll have an open discussion looking at what are the next steps, what are our asks, what do we need to do to better position both TB and TB communities in this broader health security and pandemic preparedness landscape. And so with that, I'm going to hand over to Dr. Luchika Ditu from the Stop TB Partnership to commence some of these discussions.
Well, thank you, James. Should we ask colleagues to introduce themselves quickly? That we know
Sure.
We are not that many.
Let's do that. So
just introducing each other and the country, just that people know kind of why we are here.
okay, so I'm sitting next to Pakimon, so maybe you can go first.
Yeah, I'm Nampam Budi. I'm from Ministry of Health. Now I am in the...
Endang Budi Hastuti from the Ministry of Health of Indonesia in surveillance and health quarantine program.
Hello, I'm Ella. I'm from the TBC, Tuberculosis and Acute Respiratory Infection Unit, Ministry of Health, Indonesia.
Hi everyone, I'm Jason Alacapa. I'm from the Innovations for Community Health from the Philippines.
Thank you. I'm Brendan Allen, Burnett Institute in Australia.
My name is Dean Grindle. I'm in Global Access with CEFID.
Hello, I'm Claire Cruz from Thermo Fisher Scientific.
Hi all, I'm Mackenzie Moore from the Center for Global Health Science and Security.
Hi everyone, I'm Cara. I'm from Illumina, based in Singapore.
Melinda Mori with the Gates Foundation.
Hello, I'm Zabiri Kerry from PNJ, Papua New Guinea. My name is Ilon. I'm from Papua New Guinea with PNG Institute of Medical Research.
Hi, Patrick Silborn with Genesis and the Pandemic Action Network based in Singapore.
Hi, I'm Stephanie Bain. I'm also from the Burnett Institute in Melbourne.
Hi, I'm Selena Lowe from Australian Global Health Alliance and The Lancet based in Melbourne.
And I'm Abby Minter from the Australian Global Health Alliance and Pacific Friends of Global Health.
Hi everyone, I'm Sian Yis from the National University of Singapore School of Public Health. I also work with Kanna in Cambodia.
Hi, my name is Chan Thon Pong. I'm also from Kanna, Cambodia.
ចាជំរាបសួរអ្នកខ្ញុំឈ្មោះញ៉ក់កងជាតំណាងរបស់អ្នកជំងឺរបេងមកពីប្រទេសកម្ពុជាហើយក៏មានតួនាទីនៅក្នុងមូលនិធិសកលចាអរគុណ
So her name is Nyok Kong. She is a TB survivor and also a TB committee representative of the CCC Cambodia.
Hi everyone, I'm Ramya Anantakrishnan and I'm from the civil society organization called REACH, working closely with affected communities in India.
Good morning everyone. Salamat tayong hari. Arun susday. Magandang umaga. I'm RD Marte from the Philippines. I am the executive director of a regional health, human rights and social justice organization called APCASO, and also the co-chair of the Activist Coalition on TB Asia Pacific. I don't want to speak long, but I know that Luchika is going to do her opening, but also just want to register how proud and how happy Activist Coalition on Asia Pacific is to be a co-organizer of this event. We have tried to comb through the agenda of this conference. We're looking for community. Like we keep on doing meetings, we keep on doing interventions, but we also know that we don't have to keep on doing the same mistakes of always leaving communities behind, the communities that are the most affected. And it's quite disappointing to see not much effort or investments that has happened in making sure that this conference and the discussions also, invest properly on taking along communities on board. So we're very happy to have this, that we put our banner there and looking forward to really productive discussions. But we are here and looking forward to engaging with you.
Thank you, RD. Hello, everyone. My name is Merindas Bayang. I'm from the People Living with HIV Network in Indonesia and also committee delegation of Stop TB Partnership. Thank you.
Thanks. Good morning, everyone. I'm Helen Evans, and I'm on the board of the Burnett Institute in Melbourne, Australia, and I'm also on the board of the Australian Global Health Alliance. And I just want to say that I'm absolutely delighted that RD's announcement that there's an activist coalition on TB for Asia Pacific has been set up. I think that's a great step.
Thank you. My name is Luchika Ditsiu and I work for Stop TB Partnership, and I'm really happy that we are all here together. And one thing that I want to say is we set it up this way. Ideally, I think the colleagues which are on the third row, the colleagues from PNG, maybe you come closer because you are so far away, and we usually from Geneva feel you far away. So at least here, maybe come closer. And thank you so much for being here with us.
I'm Grace. I'm assisting Dr. Luchika, and I'm a student ambassador from National University of Singapore.
Hi everyone, my name is Leslie Bola, and I'm the Executive Director for the Key Population Advocacy Consortium in Papua New Guinea.
Hi everyone, my name is Jimran. I'm part of the ACT-AP, co-chair of the ACT-AP, which ACASO is the host, and Adi just mentioned. And I am also managing one of the local NGO in Cambodia called my HIV NGO Alliance, and also a member of civil society delegation to the Stop TB. Thank you.
Hello everyone, my name is Anita Nasari. I'm from Rekat Peduli Indonesia. It's a TB survivor organization in Indonesia. Thank you.
Okay, so I think this will work. We don't need such a big microphone being in the room. It's not a large room. We have Annie. Thank you so much for doing this AV job. After I say what I have to say, I think we will go and grab the lunch. Then we come here and we can have the discussions over the lunch. I am a very informal person, and I'm a firm believer that when people don't feel constrained by speaking on these podiums, or will speak much more free. So that's why I hope that this setting will invite people to share their thoughts. And RD said something very important, which is the fact that we don't know too much about the Global Health Security Conference. I think this is, at least for me, this is the second time. First time was before the COVID. And I think is a meeting informing, and I think I think the communities, and I want to put ourselves in that group as well, will need to make the point again and again about the importance and the presence and the voice and everything. And it's sad that there are not too much lessons carried forward between different meetings, but we are very happy that at Stop TB we managed to bring not a huge number, but for the overall participation, it's good. We have, I think, at least 10, 11 colleagues that we brought here, which probably represent 50% of all civil society here, if not more. So, but we wanted to do this session for two reasons. One is when we spoke about things that are neglected, I think a lot are, I don't know if neglected, but not really embraced the voice of people that are being affected or understood or really empowered. But we also wanted to bring a conversation around TB. I work for Stop TB Partnership. Several of you are working for organizations that are giving a voice to survivors, are leading survivors for TB groups and networks, as well as representing communities into our board meeting and so on. And we struggle with TB for a long time, and we continue to struggle. And it's the year 2022, and how to say, myself and I think a few others, we are getting a bit tired of this fight, where it's like in a very sad choreography. We make a step ahead, and then we are pushed with 3 back. And even if we do 2 ahead, then we are 4 back. So overall, we are back. I don't need to tell you, you are the advocates, and I'm very grateful, and the activists of pushing the TB response, because our dream is to end TB by 2030. We don't want to eradicate it. So we speak a lot about ending, eliminating, eradicating. They mean different for epidemiologists, Eradicating means not having at all TB. We don't dream of doing that. And to be honest, as humanity, we are not doing a good job of eradicating anything, because even smallpox is coming back, okay? They found polio in London. So you know what I mean? Forget about eradicating. Let's be realistic. We are not even aiming at eliminating TB, because eliminating will mean 1 case per million. So we are not yet. We are not there. We are meaning, as well as HIV, malaria, to end TB by 2030, which is dropping the global levels at a comfortable level, at a level of around 10 cases per 100,000. So it will not mean that we will not have TB anymore, but at least can we drive down that number that goes to a level where we can much easier provide the care that is needed. And unfortunately, we had a lot of enthusiasm on TB after the UN high-level meeting, with some great progress that took place in 2018, in 2019. And then unfortunately, COVID hit us. And what we try to speak now is not just to continue making the case for TB just like that, but to make the case of TB in the context of the other situations that we are seeing right now. Because I think we all learned with COVID that we cannot fight a disease in isolation. And TB is a strong case for many things. And, and I will say this also today, actually TB doctors, nurses, laboratory, civil society were the ones that stepped in a lot during the COVID case, because you know what? They knew about airborne infection. We call about using the mask since all my life, but was not embraced till COVID. But let's admit it, doctors dealing with lungs and the infectious diseases airborne are the ones that are really pushing for that, are pushing for infection control in the rooms, environmental efforts, ventilation, UV lamps, the circuit of people being sick versus the people that are healthy, that they should not meet in the same places. These are things that were promoted and pushed for the TB hospitals and dispensaries for a long time. Diagnosis for TB using X-ray and using even the same tool like the GeneXpert one were the same that stepped in for COVID, as you know. Doctors and nurses, epidemiologists, who suddenly became, how many of the lung doctors and nurses and community health workers who were suddenly unobserved became kind of the gurus to which the televisions and everyone became suddenly a fancy disease, a fancy specialty to have, finally, you know, because for a long time people didn't care. I was contacted by offices of prime ministers in Europe to give contacts who are the reliable people in their own country that know about lung diseases, to be the ones that will come to the COVID conversations and so on. And the civil societies and TB survivors know on their own skin what it means to be stigmatized, what it means isolation, what it means having to be somehow avoided, what it means really to fight stigma and all these other aspects. So all the work that was done to prepare us for TB, all the investments done by bilateral donors, by the Global Fund and so on, were actually extremely useful in the fight of COVID. And will be useful if we continue to do it right in the fight for any other airborne respiratory disease. X-rays, even the oxygen that was procured for COVID will be very useful for the TB, as well as other lung diseases, obviously, but for TB as well. So we are not able to fight and to prepare for any future airborne pandemic without thinking in a comprehensive way. We are not able to, you see, TB makes the case not just for the preparedness response, it makes a strong case for health security as well, because we all know what it means drug-resistant TB. We all know what it means extreme drug-resistant TB. And the fact that it's airborne, okay? And nobody is at risk, nobody is protected. And what people don't realize is that TB is not as contagious as COVID. So if one of us has TB here, it's very unlikely that we'll infect any of you, leaving aside the mask. It takes longer time to infect somebody with TB. But TB is more dangerous. The case fatality rate is much higher for TB than for COVID. And according to WHO data, if you have 2 people sick with TB and they are left untreated, 1 dies over the years. It's not dying dramatically as COVID in a few, and this is one probably of the challenges of TB, is a long disease, but 1 out of 2 will die. That's the official position of WHO related to TB if left untreated. So TB makes the case of, as I said, airborne preparedness response, antimicrobial resistance and health security. It's also very well part of the One Health conversations, because as you know, we have zoonotic TB. And unfortunately, in many parts of the world, it started growing, not only from the cow as we knew, but even from the other animals and even in some rich parts of the world, such as in UK. But TB is also very much anchored, and we were just chatting here with Helen, on the primary healthcare and the community healthcare workers, because COVID should have learned us something. I don't know if it learned us that much. Is the closer we can be to the people that are sick, the closer we can be to the people that have any vulnerability, and any vulnerability that basically creates a barrier for them to access any healthcare service. The closer we can be, the better. And the closer we can be with humans, with doctors, nurses, community health workers, will be the answer. And that's why when I was saying that we should see TB in the broader context, the conversation around primary health care and the conversation around community health workers being there in the community, paid. Everyone expects the community to do volunteer work and get nothing, or get just a pathetic amount and expect to deliver. But you see now, if we would have invested for Ebola and for COVID into having a number of people in the community that are ready to step in for any future disease. They need to have a baseline of training or information, and they need to be capacitated, and then when you have a surge of whatever, they can step in. They will be the closer to the doors of everyone to come and dismantle myths, encourage diagnosis, encourage vaccination. For all of us, I live in Geneva in a neighborhood in which there are a lot of sex workers. So if we speak very much, I lived with them all the time in that area. If somebody comes and explains them, it doesn't even need to offer services, it can be just a human interaction, but they know what they say. It helps so much. But we didn't really invest in that into Ebola. So if we go now and something happens in Africa, we start from zero. And I don't know how much of the COVID investments constructed this at community level to have something to build for any future pandemic response. So that's something that we should, so on one hand we need these human parts, but on the other hand we need as well the tools, and we need to make sure that we have this, the diagnosis capacity and the capacity to search and identify people sick closer to us. And in TB, we want, and we will be at the forefront of that, because for a long time we discuss about reimagining TB care, which is meaning bringing the TB services to the door of people. And now we are first time ever able to do that, because a lot of our tools that are used to diagnose TB are being so miniaturized that can be actually put in a van or even in a backpack. And it's not just for TB, it can be happening for everyone, for other diseases as well. You put in a car a small X-ray machine that is portable these days, is this size, and it works with artificial intelligence, so you can do an X-ray. It doesn't need to be read by a doctor, it's read by the computer. Some of you are testing that already in there. And in Stop TB, we are pushing these tools out there, and I'm very proud to say, through communities, okay? We didn't really provide this to the NTPs. We provide to civil society and communities to go and test if it really works. Not just the X-ray. The X-ray would not, you do an X-ray to all of us. If we have an X-ray machine out there, we can test on ourselves. It doesn't detect just TB, it detects a lot of other diseases, God bless us, but it can do cardiovascular, it can do cancer, it can do any other form of lung disease, and even sometimes of the spine and so on. So you basically do that. Then you have a small rapid molecular diagnosis, a gene expert machine, or another one that is also small and can be put there. You can also do blood tests, you can do diabetes, you can do an electrocardiogram. So you can basically, if you have the capacity in the community and you are able to also communicate, you don't suddenly appear at the door front of people and expect them to show up in big numbers, but you have a proper way of communicating and engaging in that community, you can ensure a proper screening. And you deleted all the barriers that are happening between people and the healthcare service that we saw in COVID, how paralyzed we were. People were crying in their houses, they were unable to reach the service, and for TB, when they were going, their doctors, nurses, the dispensary, the beds were rerouted to do COVID, and they were sent back. It was an entire drama that was happening, and it's still going on. So the point that I want to make is that the red line that links all of this is tuberculosis, because it's our interest, but I don't want to make it in isolation. I want to put it in the big context, and I want to make it linked to the other things that other diseases can contribute. The future in which we will do just one disease, it's finished, or the time when we were doing just one disease is finished. That's why we encourage a lot multiplexing diagnose. And TB Reach, which is one of our teams, actually had a call for proposals in which we asked again and encouraged only high-burden countries, organizations to come forward with means and projects in which you do TB with other diseases, not just HIV, which is traditional, but can you be innovative and say, okay, if I'm reaching somebody with service, can I diagnose other things? And we got an incredible amount of resources there. We are here in this room, this is my last point, a lot of colleagues from civil society and communities. When COVID hit us, we had several conversations with a lot of you, and I am I'm not sure it happened, maybe in some places at the level that we wanted. We wanted to use the COVID opportunity to do what we said, to construct at the most peripheral level a network of civil society communities and survivors that can step in to help people in those communities for whatever reason it is. I don't know if it happened. My fear is that I am afraid that we invest money into things, they are spent and then nothing is left behind. I am also afraid that we should not miss opportunities that are coming our way and all the time start reconstructing rather than build on things that already exist. I am afraid of new, maybe funding opportunities that will start from scratch, things that we advanced in other places, rather than build on those. So that's why we need to raise a voice, because as I said, and it's not from me, it's actually from few ministers and people in African countries, if Ebola comes again, it starts really almost from zero in several places, in most places. It's not that, oh, we have this capacity that is there. It's very easy to discuss, but what I hope that by the end of this is to understand some tactics, because it's not enough to say, okay, we need to strengthen the communities, and everyone says, oh, CRG, we need to ensure gender involvement. We need to ensure that there is no stigma. We need to give a voice to communities. And so it's not about inviting 2-3 people and make a good speech, like what it does really mean. And it's not an easy exercise because traditionally there is this continuous friction, misunderstood between public sector and communities. People are always kind of scared when you say, but we were speaking before this started of this feeling, till, in my opinion, and that's the ending point, unless funding is reaching the communities and is not imposed or is not controlled, but is allowed for people to put it in the right place and decide for what the funds should be used, I think we will not arrive where we need to be. We have a funding stream called Challenge Facility for Civil Society. Started small, it's mainly USAID, and I'm very grateful to the USAID for putting this money in there. Global Fund is contributing, and but USAID is heavily, it started from 200,000-300,000 because that's where we were in TB, to 10 million. And the big increase is USAID. Global Fund now, after some time, increased as well, so there will be in the next round, I think, 1 million from the Global Fund as well, which makes it up to 10 million. But it's not about how much it is or not. The philosophy in that is to really fund the grassroots and the organizations in the countries, not big organizations from donor countries and so on, but the grassroots one, to become not only the voice, but to have the power and the strength to also represent their communities in national structures and so on, because that's not easy and it takes you guts and knowledge and the right environment to speak up. Even if you are represented, it's not that easy to be there. So we are pushing for that kind of engagement, and we are trying as well from Stop TB to do something that David Heyman yesterday in the session spoke. Everyone says decolonizing global health. What does it really mean? Well, in Stop TB we said it starts with our board. As far as our board is mainly conducted by the main donors represented there with 4 seats for civil society is not right. So we are changing that, and I'm grateful because everyone, donors and everyone agreed. We are changing that to be 50% civil society and communities among the voting members from the high burden countries. So it's not that you have big advocacy from the big north, no, high burden countries and so on. I know I made a big of ratatouille because I went through a lot of things here, but the line that I want at the end is to say how we can ensure in this very changing environment that civil society and communities are at the center of what is planned to be done in real, and ensuring that the voice and the funding and everything is there. And how do we ensure that TB, that has so many links with so many agendas these days, is not forgotten, because we as TB, we push people to see this, but I don't see the same love from the others, as we felt during COVID when there was a lot of love towards the TB doctors and TB communities and so on, which probably is not going to resist too long. So anyway, James, I'm done here. Thank you very much.
Thank you so much, Lucheka, for that overview, or for that ratatouille as you described it. I think it was really helpful to frame it, and I think as a key foundation for the rest of the discussions, it's really important to think about how we can continue to invest to build these sustainable systems to go forward, both in terms of health systems, but particularly community systems. And one of the big takeaways has been, particularly in COVID-19, that even where these systems have been built in country level, maybe they were underutilized during the pandemic response. And what are some steps we can put in place to ensure that that can be something that's changed moving forward? Now, I know a few people had said that they were hungry, and so Abby, I won't look at anyone in particular. If you want to just sort of step out and come back in, grab your lunch, there's an opportunity for lunch boxes. Please feel free to do so. But I guess we look to just continue to keep the conversation going over the course of this. And I guess it fits well to now shift a little bit to some of our community partners. And as I mentioned, we have colleagues here from the Philippines, from India, Cambodia, Papua New Guinea, Indonesia, amongst some others. And so the point of the next session is going to be just for each of them to have an opportunity to share a little bit around how some of the infrastructure for TB, and how some of the infrastructure for TB and the community systems that were built around that were also really important in supporting country-level responses to COVID-19. In addition, and I think that's what that little look was. We have Helen Evans here, who's wearing a number of hats, and so also to hear a little bit around your perspectives from those different in accordance to those different hats as well. So feel free to shift between them in terms of your response and your reflections as well. So I think I wanted to hand over to community colleagues to start, and I think our first is from Indonesia, and I think that's Annie. So Annie, I'll let you say a few comments.
I cannot Facebook Live it myself. Can you do that?
I got it here.
Oh, okay.
Yeah, there you go.
Yeah. Thank you so much, James. Yes, my name is Anita Nasari. I'm from, once again, Rakyat Peduli Indonesia, and we are from the TB Survivor. And yes, thank you so much for the Stop TB Partnership. We also, last year, we get the grant from the Challenge Facility for Civil Society, around 10. And I am also a steering committee for TB Women, and also a chief new member. And last year I also joined the TB Advisory Board. So and welcome to Pak Imran and also to Bu Endang. Our experience at the grassroots level is that moment is really hard to reach when people affected that already confirmed that they have TB. They afraid to go to the hospital because that moment we know that when the COVID pandemic we have the restricted to transportation, and then some places are locked down either, and then that moment people are afraid of being COVID too, because we know that the symptom of the COVID is similar with TB. And we from the peer organization is already have a high support to the people affected with TB. Even that moment we have minimal equipment like masking. The mask is that moment is very expensive, and then the face shield is either heavily hard to reach either for our as a peer group that moment. And that also the health facility is prioritas for COVID too for that moment. So again, we are from the survivor have a commitment to give attention and then to give support when they need to have counseling, or even that moment we also have the limitless resource, that we learn from the COVID that moment stakeholder holding hand to collaborate together to tackle the COVID pandemic. And we know that the vaccine for COVID is invented very soon after the COVID hit us. So that is for me. I leave it to you, James. Thank you.
Well, thank you so much, Annie. And I think some of those issues around having protective equipment available for community volunteers, community health workers, civil society in the context of the pandemic was something that's of critical importance to make sure you protect everyone involved in the health response, but particularly those groups who might be particularly vulnerable. It is something to really take away. But I want to now switch to Papua New Guinea. Leslie, would you like to share some of your experiences?
Okay, thank you, James. Good afternoon, everyone. The Key Population Advocacy Consortium is an organization that was formed to represent our communities through their voices. There's a very gap area in Papua New Guinea in our advocacy program because there's been lack of concentration around advocacy, but we're really thankful that we came through the Challenge Facility grant that helped us to mobilize the community. Papua New Guinea has got a very weak health system. Many of you who have worked in Papua New Guinea, it's very challenging for mainly the grassroots communities. So one of the areas that I've facilitated the process is to get the communities to have a voice. Now, in Papua New Guinea, we have 3,000 people from 2020 statistics. 3,000 people die of TB, and that's not supposed to be happening. And mothers, they die literally. They can walk. They carry them for like 2 to 3 hours just to go to the nearest aid post. And when you reach the aid post, there's nothing there. There's no medication there. And we have lots of resources coming into our country at the higher level. We're very good at talking about strengthening systems, ordering commodities and all that, but at the grassroots level, there's a very big gap area. So if 3,000 people are dying every year, there's something wrong somewhere. And so the communities have been empowered so that they know their basic rights. They have, instead of making noises through their voices, they have statistics to show our government that these are issues. So that's a very gap area with our communities because they're powerless. They don't have the information, knowledge to really tell our government there's a big issue around our communities. And everywhere in Papua New Guinea, we know people are dying of TB, HIV, any other diseases. You can't even afford a Panadol. It's really hard. So we often wonder where all this money and resources coming into our country. And so from a bottom-up approach, it's a really weak area. That's why the grant has really helped us with our TB communities to really have a voice. So we have a group called LATA, that's an organization in a province called Morobe, and they've been working their volunteering work for over 20 years. And somehow I wonder what's holding them there. And so the grant has really helped us support them so that they can be equipped with information knowledge so that we can get our government accountable to really reduce some of these issues that we have in our country. So I'm really thankful to have this conversation because we have lots of similarities I'm hearing in the room. And if we have one voice, we can get the resources at the right place, especially at our grassroots level. So thank you.
And so I think next up, which country? We've got India, we've got Cambodia, we've got Philippines. Who's feeling? India. So over to you, Ramya.
Thank you, James, and I thank Stop TB Partnership for this opportunity. I think I would like to share the experiences of the way the affected communities, whom we call the TB champions, really transformed the way in which we could respond to any public health challenge, and this time it was COVID, And who would have thought TB could actually provide a platform for people, especially the affected communities, to get empowered and to deliver public health services at the community level, and that is what I'm basically going to share. What we also realize is no matter how robust tools we have, how much the health system is empowered or strengthened, unless the communities own and participate, it is very difficult to deliver services at the ground level. And what actually happened during the COVID pandemic was that the affected communities played a critical role in finding local solutions. Now, because in a country as big as India, even 2 states are so different from each other. So, I mean, we could have all the grand frameworks and guidelines, which will all be in paper, but how do we operationalize it and take it, to the people in the community? And that is what the affected communities, the TB survivors, did. Very briefly about a background about the TB survivors, whom we call TB champions. So way back in 2016, through support by USAID, Stop TB Partnership, the Challenge Facility, and the TB Reach grants, we were able to identify, engage, and empower hundreds of affected communities who are TB survivors as TB champions. And today, the TB champions are really driving a transformative response to ending TB at the country level. The lived experience of the TB survivors has been critical in also informing the health program, especially during the COVID times, about the challenges, not only for tuberculosis like availability of drugs, but they also pitched in. So they were part of the solutions, not just bringing out the gaps, but they also were part of the solutions and helped address those gaps. And we have very many examples of how the affected communities helped, especially to deliver both TB and COVID services. Like, for example, in our Challenge Facility grant in a state called Bihar, we had TB champions acting as peer counselors. So where they spoke to other people with TB, counseled them, found out if they had TB drugs, and encouraged them for COVID vaccination. We have I think Wave 7, the TB Reach grant, where in Tamil Nadu, I mean, all of us know that especially the lab technicians were all pulled into COVID duties, right? And so we had these TB champions not waiting for somebody or additional HR to be recruited. They just put up their hands and said, okay, you teach me how to do the smear. You teach me how to do TrueNat or Gene Expert, and we'll do it. And so that's how the TB champions came forward. We have an example from Chhattisgarh where beyond TB, beyond COVID, they also looked at how to establish these smokeless chulas, which is basically for airborne diseases. How it's very critical to establish these smokeless stoves which will not exacerbate any COPDs. We have examples from Odisha, where they actually, the TB champions helped in providing linkage to social support schemes, and so that people could get the maximum benefit. Again, we have examples from many states where additional nutrition support was mobilized by these TB champions, especially for people who had both TB and COVID. Not only for them, but the family, because I think the family impact was tremendous because of isolation. So they played a critical role in garnering the additional nutrition support. So what is very heartening is that today this engagement of TB champions has moved from a model to a large-scale program, and I think that is the success of involving communities. That is the success of nurturing and empowering communities. Today, the public health system considers them as true partners. They consider them as allies. So it's basically a win-win situation for everyone. So we have these TB champions going through an incredibly empowering experience. We have the people with TB, people with symptoms of TB, people with COVID, receiving services. We have the health system partnering with these TB champions, and the TB champions literally are the eyes and ears of the community, bringing back the gaps. So it is, I think investing in communities has played a very critical role to take not only TB services, not only COVID services, but here is a group of people in the community. They are the go-to people in the community. They are recognized as leaders in their communities, and they are people who are ready to respond beyond TB, beyond COVID. They are asking questions. How can we support NCD? NCD is a huge challenge. How do we address that? So I think for us, working with the affected communities, we started with tens and hundreds, and now it's thousands. It's a very humbling experience for us to see how it's expanded. And these are people from all walks of life, not just a few elite TB survivors, from all parts of the country, all parts of the people, and who are responsible for bridging that last mile gap. So I think in closing, I just like to say that I think investment in affected communities, empowerment is very, very critical, not only for any public health diseases, but the empowerment that they personally have. Like many of these people, for the first time, have stepped out of their homes. First time they come to a meeting and they share their experience, and they are never able to share it without breaking down, without shedding tears. And today they are empowered to actually speak to ministers, speak to bureaucrats, to speak in various forums at national, state, international level, talking about these challenges, advocating for better services. And I think that is what is very, very transformative, and I think we are completely sold. Very happy to see that the program also believes that investing in communities is very critical, and because they have taken it up and they are planning to scale it to 15,000 TB champions across the country. So I think we are very, very happy to see how the affected communities have shown through their work that they are important players in any public health response. Thank you.
Thank you so much, Ramya. And it's fantastic to see how the seed funding can grow to be sort of a mainstream government response, and from everything to lab to social protections to peer support, and across multiple disease, endeavors. I think that goes right to the heart of the discussion here. So now to also hand over to Jace from the Philippines.
Thank you, James. So I'm Jason from the Innovations for Community Health. It's an upstart nonprofit member of civil society in the Philippines, just 3 years old. We're doing public health delivery, implementation science research, and advocacy. And we've been fortunate to be blessed to implement several TB Reach grants, CFCS grants from Stop TB Partnership, and also some grants from USAID and from the Global Fund. So having said that, I'm going to share our experiences back in the Philippines. As you may be familiar, Philippines is one of those high-burden countries for tuberculosis. Now, I'm proud, or not proud to say that we're not only high-burden for drug-sensitive TB, also for drug-resistant TB, and also for TB and HIV comorbidity. And interestingly, as we know, COVID-19 has reversed at least a decade of our progress in terms of fighting tuberculosis. The same investments used to fight tuberculosis, interestingly and serendipitously, provided returns so that we could fight another disease entity, which is the COVID-19 pandemic. And this was highlighted in 2 examples that I would like to share to you. These 2 examples, just a disclaimer, we were either a direct implementer or an indirect collaborator with many different colleagues back at home. So the first example that I would like to share would be related to bidirectional care. And second would be the use of the community-led monitoring framework with the Stop TB Partnership toward data-driven response and a more responsive care. So first, for the bidirectional care. So investments in screening using digital X-ray and gene expert for TB paved the way for bidirectional care. So basically, we harness existing soft and hard infrastructure existing within the country already. So with the government overwhelmed with the ensuing pandemic, so basically what we did, just like in other countries, we converted our existing TB gene expert facilities to also take care of COVID-19 screening. Also, another diagnostics or screening modality that we have expanded is the use of digital X-ray. So we have been fielding digital X-ray equipped with AI in different key affected populations. But this time, during the pandemic, we were not only screening for tuberculosis, but we were also screening for COVID-19. We have fielded these mobile van X-rays to COVID-19 vaccination centers, COVID-19 quarantine facilities, and it made us detect more cases of not only TB but also COVID-19. So now, where do the inputs of the community comes in with this bidirectional care? Good thing, we also have another investment from USAID in which instrumental in terms of developing a network of different TB advocates and survivors. Network of TB advocates, a national network. And they have been closely involved in terms of developing guidelines, frameworks of where to deploy these services, how do we make sure that we don't prioritize one over the other, marginalizing TB or COVID-19. So the key here is having this informed TB network so that, at the end of the day, our care is not only responsive, but it's also equitable. Now, for the second sharing, I mentioned about the community-led monitoring framework, in which at the heart of this framework developed by Stop TB and adopted in many of the countries here in this room is the accountability framework. So with grassroots data, governments can make informed decision-making toward a responsive care. So in the Philippines, we collaborated with the WHO Philippines, and we have launched a digital platform called Care TB. And one big component of that is the CLM framework. It's an application also at the same time as a Facebook chatbot, because Facebook is very popular in the Philippines. It's free to access, so it may be more accessible to people at the fringes. So with this mechanism, people were able to report different concerns related to their TB care, different abuses, different concerns such as stockouts. And although this was originally intended for tuberculosis, because it was already there, it was also used by patients for COVID-19. So now, having said these two examples, perhaps some two reflections that I would like to share as I end my sharing would be that first, it's the importance of harnessing existing infrastructure in these countries. One good learning is that TB appeared to be a sentinel for a plug-and-play model for similar or future pandemics. The second reflection would be that, as what was rightfully mentioned by my colleagues, is that people should be at the heart, front, center, middle, back of all the things that we do. Because at the end of the day, these are the people that we are serving. Now, in retrospect, without these TB investments, be it in healthcare service delivery or through community advocacy, I'm now thinking, where would be the Philippines be in the grand scheme of things in terms of the COVID-19 pandemic if we don't have these TB investments? I don't know. Maybe much worse where we are currently. That's all. Thank you very much.
Thanks so much, Jay. So now we're going to go to Chambun from Cambodia, and then I think we'll open it for discussion, but I think that I'm going to call on Helen after Chambun just to sort of share a bit more of a perspective from both Australia but also from the global level as well. So Chambun.
Thank you, James. I just would like to add to everyone. So first, thanks a lot to the Stop TB for support to have this kind of exchange perspective and the lesson we learned from how the support to TB program, to TB community can support the health response. For us, especially Kana, we grow up from HIV, so we start from HIV. We have a lot of experience from doing this kind of pandemic for HIV from the beginning. So we start with seeing people dying day to day in the case of 90. And then we start home-based care in 2000, where community are working alongside with healthcare provider to set up and to team up as what we call home care team. So later on, this team continue providing services. And we would not see more people dying, but people accessing services and life-saving treatment. So right now, we continue to be that part, and Cambodia, I think most of you know, we are successful in response to HIV. So the lesson that we learned is using from that community mobilization in a response to TB. So luckily, we got support from Challenge Facility for Civil Society, and then we built up the similar model And most of the model, including case finding, screening, we use the model from HIV to support TB, and that from the community mobilization strategy. So we have support from the challenge facility to support us to do support people to establish their group. So right now we have peer support group around 100 peer support group across the high burden, what we call underserved district where TB. So these group, they exist around 25 people. You can imagine they have 2,000 plus. A community on the ground where they work alongside with health center, liberal hospital. And during COVID, these are the people that continue to bring those people who having TB to continue accessing TB services. But importantly, they are involved in providing what we call peer counseling, because COVID have a lot of stress, have a lot of depression. But these people continue to support their peer, but also support other who have comorbidity, for example, people with diabetes. In addition to that, because of this network, we've been able to work alongside with people living with a network to call for immediate action from our CDC to have PPE for our healthcare provider, because in 2000 and 2011, where we have community outbreak for COVID. So we need PPE and we also need vaccination. And because of this joint network together, because of the support, we have been able to invite Excellency Dr. Lee Suvan to come on board and share information about COVID. Because understand, people living with HIV, people living with TB, you cannot access vaccine. That is the message. So we said, no, we know that we should be able to access vaccine. And then we invite, and then they come and then do presentation. And finally, our healthcare worker, the Ministry of Health, declared that, okay, you can access vaccine. So all of us got vaccine, and we continue to do our job. So if we don't have this kind of network working together, TB, HIV, we cannot build a movement, right? A strong movement. So this is very important. The second thing, everyone in TB program, they have to respond to COVID. So no people in taking care for TB as well as for other healthcare. So we said, no, can we have someone stand by? We do need COVID, we do need TB, but we do need other healthcare. So we call and we invite for discussion and dialogue, and we share information. So I think, again, this is another experience that we join hands is very important. So without having this kind of people group together, this kind of network being established, maybe it's very hard, right, to challenge within the time that everyone put priority to one thing. The other aspect that I see important of having support from challenge facility to the network is the supply of information. During COVID time, it's very hard to get information. Everyone need information to plan, to submit to the C19RM. But because of CLM that we already established, because of the network already on the ground, so it's easy for us to supply information. And then the country C19RM application can be submitted using all the rationale that we have. And not just for TB, but also for HIV, because we do both sides. And we plan ahead. We plan 2 or 3 months ahead of COVID. And because we plan, not because we know COVID, but because there is community there on the ground. They supply information. They give the real information that related to CIG. So the information submit on time. The other aspect is some people already mentioned, some of our colleagues mentioned about social protection. Our network, because they are grouping, they can share information among each other. HIV people talk to the network of people living with TB. I got my ID card as entitled to poverty scheme, something like the COVID scheme of the government. Why not you? Something like that. So we're using that platform of network. Our network for TB also access to COVID-19 government scheme. So those who are better off before COVID, and then fall down because of COVID, they can access to livelihood and also to government cash transfer. So that is another aspect. And the last one that I would like to mention is around those who train in leadership from the network of people living with TB, because they are so active. Some of them have been invited by the political party to join hand with them to get the vote. So some of them got the what we call commune council elected now. The election just happened early June, and some of them only got elected. So it means that it start from being a person of living experience TB, now they become a commune council member for their locality. So they can do more, not just for TB. They can do other aspects, and they can do empowerment. They can do peer support. They can do many things. And now the government is putting decentralization scheme, all of that. These are the right people, because they've been trained, they've been supported, and they've been active for their community. That's why their locality, their representative in that locality been elected. So it means that this is, I think that is very important. So thank you.
No, thank you so much, Chamroon, and I know Jace for the bi-directional services, community-led monitoring, and Chamroon for that very comprehensive piece, but also noting the peer support, access to information, leadership, and building community movements that are starting, I guess, through something that's seed funding, but now almost becoming centralized pieces of local administration and governance. So really excellent to hear. But I'm going to now hand over to Helen Evans. I'd just like to hear your reflections just about some of the things that you've heard, but also your own experiences reflecting on, I guess, COVID, investments in TB and other health systems, and also what we can take or think about further looking forward in the future around broader health security and pandemic preparedness discussions. Thanks, Helen.
Thanks very much, James, and thanks everybody. It's just been fantastically rich information sharing. I'm so encouraged and inspired by what people are doing, the examples of what you've done on the ground. When James asked if I'd be on this panel, the title he said was Reflections from the Ground, Lessons Learned from COVID on Health and Community Systems Intervention. What do we learn from COVID? What should we do more, better, and what should we never do again? And that was in the context of TB. So I felt like a bit of an imposter, because I have to say I'm not working on the ground. I'm actually now, at this stage, I'm much more at a governance, an evaluation, an assessment level. So that's what I'm going to reflect on. And I'm going to draw on sort of, I think, three roles I'm playing at the moment. I mean, one is as a board member of the Burnett Institute, and I'll talk a little bit about what Burnett's done in relation to that. The second one is that I'm actually on the technical reference group of the Australian Government's Indo-Pacific Health Security Centre, and so what I've learned from that and what that's been doing. And the third one is that I'm the Vice Chair of the Global Fund's Independent Evaluation Group, so we've been doing a range of evaluations, and that's also provided a lot of really fascinating insights into what's working and indeed what's not working. I mean, some things are working really well and some things we could do a lot better. So I'm going to just draw on that briefly, but then I want to pull together, as James said, I really want to pull together what these examples and others, what are the lessons, what are the key lessons on the ground now and then moving forward. And I'm also going to respond to James's question about what should we never do again. So, because I think it's really important to look at that. I think it's really important to look at what's been positive and achieved, but it's also important to look at what hasn't worked and what we need to do again. So just briefly on the Burnett, as I said, I'm on the board, so I don't have the on-the-ground experience, but the Burnett, it's a very interesting institution in Australia. People may not know about it, but it's both a medical research institute and it's registered as an international NGO with the Australian Government of Foreign Affairs. Now that's pretty unusual. So it has a very strong commitment to move from really discovery and operational research right through to implementation on programs that are evidence-based. And that's why I really like being on the board. I think it's a really exciting model. And they've actually been involved in partners for 5 current TB grants in Indonesia and PNG and also Timor-Leste. and there are 2 other grants where Burnett's part of a wider consortium. And I won't go into details of that program, but Stephanie, who's here, can give you details. She's the on-the-ground lady who can tell you much more detail. But I did want to just comment on one of the examples of Burnett's experience, which is prime TB in PNG and Indonesia for micro-elimination of TB. And that was really interesting because it started in Daru in the Western Province, which you all know well had an absolutely huge concentration of multi-drug resistant TB. The focus was on micro-elimination. So they worked very closely with communities, and I think this is a really good lesson, that the focus was very much on engaging a pilot on continuous quality improvement on an evidence-based model for care and emphasis on research, treatment and prevention. You can see I'm reading from notes here. And because it was at micro-elimination level, there was a very strong focus on supporting and developing the local workforce and community engagement and health material development. And in fact, between 2013 and 2018, treatment success increased from 50% to 83%. So I think that close community engagement was really important, which just reinforces all the comments you've been making. But for COVID, it was really important because it meant that community engagement and trust had been developed at the local level. So when COVID came along, the workforce could actually then go out with a vaccine. And you may or may not know there's been huge vaccine hesitancy in PNG, which has been a very big issue. But in the Western Province in Daru, there was a higher rate of vaccination, which was probably, you have to be careful about the evidence, was related to the fact that they trusted the workers and they had a trusted relationship with the communities. So that's just a quick example from Burnett, but I'd encourage you to talk to Stephanie if you want more examples. The Australian Government Regional Centre for Health Security, I'll just give you some rather boring dollar figures, but they are important. I mean, the Australian Government is a contributor to the Global Fund, which, as you know, it provides 70% of external funding for TB, so it's a very important funder. But the Australian Government also provides $15 million a year for TB programs in PNG, and in fact they funded the Prime TB program that the Burnett was running. And the Centre's also invested more than $8 billion to the TB Alliance to develop new TB drugs, and $26 million to FIND to develop diagnostics for TB and malaria. So, I mean, that's a lot of figures, but it's actually really important in terms of funding programs within the Indo-Pacific region. But I wanted to give another example of what the Centre's doing, which is they've funded a regulatory strengthening program. That may sound a bit boring, but the Australian Therapeutic Goods Administration, the TGA, is a stringent regulatory authority, and it's funded to do work, and this was happening before COVID, with key Indo-Pacific countries to improve regulatory systems and process and share information, predominantly on new drugs and diagnostics for TB and malaria. And this is really important because you'll all know that there's a real struggle if you don't have the capacity to actually get the drugs and the vaccines approved officially and allowed for use in the country. So I think this was a really very positive initiative of the Australian government to twin with regulatory authorities. And then when COVID came along, they actually strengthened their focus on helping countries who wanted the assistance, to be able to approve, first of all, the vaccines and then the treatments that are coming in. The third one, which I'm not going to talk about in any detail, but there are 3 key evaluations that this independent group has just done for the Global Fund, or we've oversighted and contracted out. The first one was how did the Global Fund's, what's called C19RM, what did that deliver in the first year? And that's a really interesting evaluation, which will actually be public in the next couple of months, about what are the lessons learned, what worked and didn't work. And as you know, Global Fund isn't an emergency operation organisation, so it was quite a change for them. But they did move on that. The second evaluation we did was on community engagement and community-led systems, and I can't talk about it too much because it hasn't actually yet been to their strategy committee or the board, but I think that you'll find it very interesting in the insights there. One thing I am going to say, which won't be a surprise to any of you, is that supporting community engagement and community-led initiatives, it probably requires a different sort of funding modality to the traditional applying for grants. And I think this is something, this is me speaking, but this is the report, the evaluation says this, it's something that really needs to be looked at. As we've heard today, community systems evolve. You can't put in a proposal that says, this is how we're going to do it, and this is what we're going to deliver in 3 years' time. There actually needs to be some flexibility to allow it to evolve. And there also needs to be some flexibility to allow for a bit more risk, because, you know, capacities are often a bit more limited. So, yeah, I think that donors need to look, and I think Global Fund, hopefully, in the next iteration, might look at more flexibilities around community engagement, because it's a key part of the new strategy that's coming, and to really be able to deliver on that, I think there needs to be some rethinking. I've probably said too much because that report's not out yet. And the third one, which is, excuse me, also not out, is actually on Global Fund funding for TB prevention. And that's got some interesting insights into it. So what have I pulled out from all of these examples? What are the key lessons from COVID that it's taught us? Now, a lot of them you've already mentioned, and Lajika, not surprisingly, you also mentioned a lot of them. But I think that the infrastructure for TB detection, diagnosis, community-based treatment, care and prevention, it was really an integral part of pandemic preparedness and response. I mean, a lot of you have said that, but I think we shouldn't underestimate it. And it's important looking forward to look at respiratory pathogens more broadly, rather than just taking a siloed approach. And this should serve as a basis for airborne disease, pandemic preparedness and response. The other thing that happened during COVID, which a lot of you are familiar with, is that the TB leaders were actually pulled off and moved to head up the COVID leadership. And that left a big gap in the TB programs. And I think that's something we really need to learn going forward. But it's a broader lesson than this. It's reinforced for TB the importance of integrated care in the primary healthcare level, decentralised to the local level. And Lajika, you were commenting on that, but I think this has been really reinforced. And the training and ongoing support of local health workers leading to more people-centred care, and in fact leading towards universal health coverage, which is a SDG we're all looking at. It's also, I feel almost embarrassing this because you're the experts on it, but it's also reinforced, I would hope, the key importance of engaging local communities as partners and tapping into the knowledge and capabilities of civil society. Infectious diseases control is really so much about human behaviour. It's about trust, it's about cultural practice, which varies not only between countries, but it varies between regions. And that needs to be taken into account. You would have thought we learned that lesson from HIV, and if we hadn't learned it from HIV, we would have thought we learned from Ebola. But I'm afraid we sort of had to learn it all over again. So let's hope going forward we don't need to then learn it again when the next pandemic comes along. And that also includes how information is best communicated and how to proactively manage misinformation, because that got out of control, really. And part of this is to recognise the negative impact of stigma and discrimination, not only on the lives of people involved, but also on infection control and prevention. People will not come forward, people won't go to be tested, they won't go to clinics if there's stigma and discrimination. Once again, I'd call this Public Health 101, but I hope it's now better understood in the wider community. So maybe that's a positive. Maybe the wider community have learnt, instead of saying this is something that affects other people out there, that this is something that everybody needs to be involved in. One of the other lessons is interruption of services because of lockdowns or reluctance to attend clinics, and the reduction of monitoring visits. And this is, as a result of this, there's actually been an increased use of video and other methods such as apps, WhatsApp for patient monitoring and review and for online training. And while there were downsides of that lack of access, we've learned a lot. I think that's a positive. We actually have learned a lot more, and hopefully it will push us a lot more across to how we can use that. There's no substitute for face-to-face, but we can do a combination now, which I think is really important. The other, I'm nearly finished, James. The other is the importance of planning for surges. To be clear about what activities can be reduced and put on hold and when. It's a more comprehensive planning rather than just everything being shifted across to the pandemic. So hopefully we can have some planning ahead of time. Once again, a no-brainer, routine use of indicators for monitoring and evaluation, which makes possible informed decision-making and accountability. There's a focus in many countries on centralised data collection, which limits the investment in local data analysis and then how we use it for responses. And this leads to a much less effective response when we only have it at the national level. So just briefly, what do I think we should never do again? Poor communication, not crafted for local communities and or subgroups as mentioned above. In Australia, I was shocked at how poor our communication was. And, I would have thought a wealthy country like Australia with a huge amount of public health expertise and a lot of political support, the communication was really very inadequate. So I think we shouldn't ever do that again, I hope. But I would also say at the global level, WHO was very strong to acknowledge evidence. So we're very strong to acknowledge the evidence about airborne transmission of COVID. And I think that a large amount of money and time was spent on some limited and likely ineffective COVAX prevention. Get switched off. COVAX prevention. Now, I know that our knowledge of how this disease was transmitted was evolving all the time, but I think a bit of speedier transmission of those sort of pieces of evidence would have actually helped a lot. Another one was the inadequate provision of PPE. The importance of support for staff just can't be underestimated. There's been quite a lot of comment about this, and then that relates also to the role of women, because women are often at the front line. But we just weren't prepared for PPE, and we should look at how we can do that better next time. And the last one is the interruption in essential services to focus solely on outbreaks. This was the point I think our Cambodia colleague was making. We actually need to be able to continue the other key services, and how do you find the mix? So I'll stop there. Thanks.
Thank you so much, Helen. I think it was really, really detailed and a lot of things to really continue to discuss here. So I guess at this point we really wanted to open it up for questions or other comments. I know that there's others from Burnett who are in the room, other colleagues. I remember Gates, I remember Georgetown. Any of you who, please feel free to also contribute, but also the other country colleagues at the table. So colleagues from Indonesia as well. But we can keep it flexible. But Daniel, I see you raised your hand. But please, everyone, just jump in as you're ready to go.
Yeah, thank you, James. Since a lot of civil society and government representatives here in many countries, let me share the lesson and what we have been doing in the country level. I'll make it very short. There are two things I would like to raise about the integrating and collaborating actually. So my organization right now is a principal recipient for key population and for HIVs in HIV. But my organization since 15 years ago or almost 20 years ago already integrating TB HIV in our programs, but with limited capacity, limited program and funding. But when we become a PR, before as a SRs and PR, we have a capacity there. And we have the opportunity. The important thing, we have the opportunity, then we integrating the program TB with HIV together without any specific funding, without any requirement from the donor. It's become the initiative because we have resources, we have the capacity, and we just expand. When we integrate, we get more. So in our program in HIV, we integrating with the TB, we integrating with STI, we integrating with hepatitis. So we screen them, we reach them, we refer them to the testing, and we refer them to the treatment and support for the adherence for the TB thing. This has been working for many years. No requirement from the donor, no requirement as an indicator. That's totally initiative because we have the capacity, we have the opportunity. That's one. The second thing, we just have been doing PLHIV partner notification. Now we reach PLHIV with the partners during 2 years, more than 2 years. We reaching thousands or maybe already more than 50,000. We screen, we reach screen and then bring to the test, and we get every semester the positive rate 30%. There's a very big positive rate. In the key population, the positive rate just less than the 10%. That's the way how we creating to reach more people, and they get screening and refer testing for TB and hepatitis STI also. That's another lesson learned. During the COVID, actually, in many PRs, many countries, they cannot achieve their program. They cannot spend their money. We did a lot. We spend a lot and we achieve a lot there. Why we create so many innovative things? Like during the COVID, we married COVID with programs. So when the communities come for the COVID, then we married with the HIV program, they get the testing. That is success in some places, cannot be in every place. So we can merit for TB also. We can build awareness there because it's maybe 70% of your population will go to the vaccine testing. So give the opportunity for information and build the mechanism how they can get the screening or testing. So that's about. In the COVID situation, we create a new innovative way. We come to the people. We come to the client, we call door to door. So we create the mechanism, we pick up the ball, and 1,000 people we can door to door, and we get more people on testing, on treatment, and other things. So I'm thinking, if we are as a CSO, if we are as a government, and when we know we have a capacity, and we know we have the opportunity, you need to expand. You need to integrating all the programs. Like, with the COVID situation, now government or primary healthcare, they strengthen now. They know how to deal with the thousands of people during a month to treat them, to screen them. Because of COVID, they get a lot of tools there. So how we can integrating to put other diseases, like Lucika just said, the tools is almost the same for screening, for testing, and it's also for TB HIV. So there are a lot of opportunity if we realize and we wanted to integrate all the program among the CSO, among the donors, among many things. I think that's a good way and start with an innovative way. Thank you.
Thanks, Daniel. Over to you, Adi.
Yeah, hi again, everybody. When I was listening to all the sharing of the civil society colleagues, and of course, wonderful stories, particularly coming out of support that has been invested to community mobilization, that's good to hear. But I also think it's important for the room to note that those are the good stories. The investment for community mobilization, particularly in TB, is not enough in our region. So we've highlighted the good story, CFCS, the Challenge Facility for Civil Society, which civil society in TB in the region is so grateful to have via the Stop TB Partnership, is one of the only, aside from Global Fund investments of such kind, that actually supports TB community mobilization, TB community advocacy. It's not enough. Like we hear good stories. It's not reaching the level in terms of geographic scope or the breadth and reach that we need to reach. Because the unfortunate thing is, until now, CFCS has investments from the US, investments from the Global Fund. I am actually happy that there are colleagues here from Australia. Australia used to be a champion of support in the region, particularly for key, vulnerable, and marginalized populations, particularly for human rights, for gender, and for community system strengthening. In the recent administrations that has really fallen apart, we have a term in the NGO in Asia Pacific. It used to be AusAid, and then it became Lost Aid or Was Aid because it disappeared, and that really hurt the region. Like my organization was one, I mean, Australia has been such a supporter of regional initiatives. Now it's going back to loving very much bilateral support, which of course, like they have their own agenda, but I think we need to bring Australia back in terms of being a champion in the region. There's a lot of supporters for Africa, and it's not that we're competing against Africa, they need the support, but I have to tell you the picture in terms of assistance for Asia Pacific is very, very grim. When I attend international meetings and they talk about community responses, it makes me, I don't know, react because they say, okay, support for Africa and others. So Asia Pacific becomes others. And I do note that there's a reason for that. The economic development in countries in the region is advancing, but it doesn't mean that the key populations are also advancing together with the countries and the government. And I really want to call out to donors, particularly Australia. I don't know if you'll also be able to reach US, etc., to increase investment and even maybe consider investments, particularly for the region, for community interventions, increase investment to CFCS via Stop TB Partnership. We need to do a lot more. I don't want us to fall into this notion that because we hear good stories, and there are good stories, that we've done enough, we're not doing enough. And then aside from that, when my organization, APCASO, has also been facilitating conversations on COVID responses, pre-pandemic, post-pandemic, one of the interventions from our country partners is to say, especially for example, within CCMs, which are managing global fund grants in the country across HIV, TB, and malaria, in our region, which experiences a lot of disasters, quote-unquote, so-called natural disasters. There is now COVID. There would always be a pandemic in the future. It shouldn't be something that gets responded to. How they call this? Reactionary. It should really be already part of the reality. So the preparedness within the CCM, the preparedness within the community, the grants within the community should already have that as part of the full scenario rather than having like a specific special response when it comes, because they would come. But the bottom line also is COVID has come or is still here. It might disappear or it might not. There would be other pandemics that would come. Governments also come and go, and they do play a role in responses in the country. Health service providers also come and they go and they stay. But definitely who would stay in the country are the communities. And it's the communities which are actually the backbone of resilient and sustainable systems for health. And what we're hoping to see as countries develop at the national level and at the global level, bodies that take care of pandemic responses and pandemic response frameworks, we're seeing them develop without communities and civil society. And we're really not learning lessons, and what we're calling for is that as countries develop frameworks for pandemic responses and preparedness, and as bodies get developed, then there should always be that mechanism to make sure that the civil society representation is also institutionalized, the way that we do it in CCMs. We don't need to keep on reinventing the wheel. We already know what makes things work and what doesn't make it work. And it's quite annoying that we still expect the same, how do you call this, errors to give us like positive, successful results.
Thanks, Adi.
Thank you. Brendan from Burnett Institute. I'm also not an on-the-ground person, so I guess my role at Burnett is much more around our funding partnerships and our partnerships in country with the organisations we work for. So my reflections are probably more at that level and the role of the partnerships that we've had. Helen mentioned some of the TB programs that Burnett has been working I think the distinction with those programs are that they're all consortium grants. So we're working with other institutions, and many of them are also multi-country grants. So just the pure nature of that has allowed some really, really good collaboration and information sharing between countries. PNG and Indonesia, a particular example. And also within Australia, the information sharing between institutions as well. So I think just the nature of the shaping of those grants has allowed some fairly quick information sharing, quick acknowledgement of lessons learned out of the program, as well as, excuse me, things that shouldn't be progressing. So I think that has been a really positive response in the TB, being able to support those the networks across countries as well as in country. I can't speak to the Australian government other than I fully agree with the need for additional funding, additional support in the region. There was the incoming government, or the current government, did announce quite substantial increased funding for Southeast Asia as well as the Pacific. We're yet to see what that will look like from an NGO perspective, but I remain positive.
Thank you so much. So coming back over to Helen, but I think it's good to hear both that context in Australia to understand some of those lessons learned, those opportunities for complementarity, but I guess also those opportunities in the coming months to maybe bring some of the discussions that you're hearing in this room to those discussions in Canberra and elsewhere as well, because that's, I guess, a big entry point and opportunity to do some of the things that some of the country partners asked for here today. Helen, please.
Yeah, no, I just wanted to add to what Brendan was saying, but also to acknowledge Selena Lowe and Abby Minter, who are representing the Australian Global Health Alliance, and one of the Alliance's roles is advocacy. So I think it's really important, and we'll be taking all that on board. Yes, looking at them both nodding. But I guess I want to make a broader point that comes out of your comments, Adi, and Brendan's comments, and that is the importance of political leadership. I mean, we saw in Australia the major difference with a change in government, but we've also seen across COVID that where there was strong political leadership at the top, it just made a huge difference. So while none of us have the capacity to influence that, I think that it's important to acknowledge that it is actually a key part of response. Yeah.
Thanks so much, Helen. I think colleagues that you were put on the spot a little bit. Did you want to reflect on this point, or no? So Luchika, and then I'll go back around.
Just very little here, building on this wing of Ardid and Ellen, but also on all of us. So it's true, we wanted here to showcase the positive things, right? And that's why they came up. The reality, the cruel reality on the ground is that these are like sparks, right? Yeah. The sparks can end. It's like you have the nice sparks and you are like, wow. Yes. And you see how much beauty can happen. And then you turn your head and then you see that nothing is happening if we don't manage. Peter and Lady Rose around the table somewhere, we kept some. So, and welcome to us here in a right moment, because we just speak about the sparks that we can build with civil society and communities if properly funded. But how do we ensure that the sparks remain lights that will stay there? And the reality is that I want to say this region is not the only one. I am from Europe. The European region as well, outside the Global Fund, the only other donor is USA. The rest don't give anything. So it's a bit sad that you have these regions in which for TB, there is very little coming from the region itself, or nothing, okay? Separate that what Global Fund is trying to do. And that's another, you look at the European region, is the US the biggest donor. And you have here, we also speak the challenge facility is 95% American money, which is very good, God bless them, but it's kind of a narrative that doesn't fit very well. And the difficulty, and this is the last point with the sparks to continue staying, is that this is not, you expect basically that the governments will embrace this, the community's work, and at a level this will become sustainable, and then there will be funding coming from the government. There should start building a way in which the governments will contribute. This cannot be forever supported by Global Fund or by the American government to fund civil society, because then you have this crazy conversation that is happening in some countries, including in mine. People say, why are the Americans funding the work of civil society in Romania again? Literally like that we were asked. So you need to make this sustainable. But you see, in TB, to make it sustainable, it's like when you have on a table enough just to put bread and water. And a lot of people see the civil society work as a cake. So they say, if I don't have enough for bread and water, I leave the cake for later because I just need the bread and water. The NTP managers here in the room, which are 2 or 3, they know how difficult it is to secure even the means for diagnosis and treatment. So a lot of these other things are seen as a luxury, which are not. But if you are in their shoes for years of underfunding, of trying to deliver with 30% of money, maybe we will arrive in that same mindset. So funding for civil society and communities properly done will be absolutely essential. I just wanted to add my voice to what everyone here was saying. It is about Australia, but not only about Australia, as the region has many more other donors here. Thank you. James, I think Imran was next. And then, so thank you so much, Lady Ross and Peter, coming and joining us.
Yeah, thank you. Thanks, Rusika. So I think what I see from my view in the health quarantine, because I am now in the health quarantine, so a lot of deported foreigners and deported from the others, especially for the migrant worker. Many suffer for the TB when they come, and most of them are dropped out. So it means that this will be much higher pressure for the program in each country, because they are deported and they are dropped out. So the things that we should have the what we call monitor, not only the patient that we already registered, but also not registered, because they came from the foreign for migrant worker. And the second thing is that I want to mention that I think all the programs, health programs, have impact with the COVID, right? So immunization dropped 50%, and also the malnutrition is also increasing again. So I think TB is not alone. TB is similar with the other program. So what the point is, maybe I want to raise this issue that we should use the investment on the COVID to convert to TB treatment or TB program. Because I think COVID ward, for example, in the hospital, because during pandemic, government built or developed many beds of COVID ward. And I think the COVID ward can be used for the TB, especially for the AMR, right? Yeah. For the negative pressure. So we can use this one. And laboratory, PCR, PSL2, it's very hard to get before the pandemic. But nowadays it's 1,000 maybe, or hundreds. So we can use this one to be a TB laboratory. So, and also important is information system. We build information system especially for the laboratory. So it's not happen only in 6 months. So we can use this one also for the TB program. So let's think that how we can use the legacy of the COVID to use to the TB program. And also connecting with Mas Daniel, what about the bidirectional screening? I think not only vaccine, but also how we can use also bidirectional screening with the nutrition, with the what we call nutrition monitoring the childhood, because it's also important, right? TB childhood, I think now is raised also, and the symptom of the TB in child is not cough, but nutrition. So we can vice versa. We can find the TB in the child, and then we can trace where is they get the TB, right? Or vice versa. And the third, I think that's mentioned also with Uchika about advocacy. So I think the civil society can have impact for how we can move forward. Like what I mentioned, that, for example, the local society, the local what we call civil society can say to the local government, look, the ward, the COVID ward in hospital is empty now. How can we use this one? Just simple like that one. So I think what we can use is we can monitor very perfectly this one. Thank you. That's my view. Thank you.
James, can I just say one thing to build on what Dr. Imran said? Before I know you wrap up and you move to Pira and Lady Ross. You're absolutely right. You know, there are countries in which there are currently empty beds with negative pressure maintained there, they should be maintained. But if you, in the meantime, run out of space for TB, what's so sophisticated to do this? But what appears as bon sense, like we all know it here, is like, it's not happening. And then everybody constructed a lot of apps and tools for COVID monitoring for that. It's only one country, Azerbaijan, which is not even having such a big number, who said, we want to use it for TB. Whatever was there, you know, like to inform, to whatever, because everyone downloaded and have the COVID apps on their phone. Many places think to just drop it. It's insane. So a lot of money went in constructing some tools that can overnight become obsolete just because people are not thinking. Anyway, it's crazy. Yes, thank you. Thank you, Bakimra. Thank you.
Thank you, Chika. Thanks, Bakimra. So, Peter, Lady Rose, thank you so much for joining us for this part of the discussion. So just before handing over to Dr. Selina, just to give you a bit of a background about some of the things that have been discussed so far this afternoon. It's been very much a discussion, I suppose, looking at some of the strengths that have emerged as a result of investments historically in TB that supported national level COVID responses. At the same time, there was also some discussion about some of the challenges that have been experienced and some further lessons learned that maybe shouldn't be repeated going forward, or things that we can learn from to help strengthen broader efforts in health security and pandemic preparedness. We had a number of speakers from community and civil society partners in the region, including from Papua New Guinea, Indonesia, Cambodia, India, and Philippines. And there was a lot of reflections there about some of these initial areas where investment has been seen in TB that was of utility in COVID efforts, and it ranged from everything from bidirectional screening and testing to community-led monitoring, advocacy, social protection systems and peer support, access issues as well as, I guess, a range of things around the issues of information, leadership and participation. I think a lot of the community partners also reflected, I suppose, on some of the seed funding that had gone particularly to develop capacity, organisation and mobilisation to ensure that these sorts of things could occur, and then the need to continue to make this investment and to scale up this investment going forward in order to, I guess, contribute not just to ending the TB epidemic, but also for health security and pandemic preparedness. So I think now we're sort of handing over to Dr. Selena. I think the next session is very much looking at this opportunity of financing of TB, PPR, and health security. But I suppose also to link it to this discussion for opportunities to really leverage some of these key areas as well. So Selena, over to you.
Thanks very much, James. It's been a long time since I've been titled doctor. Although I did work on TB programs a very long time ago. First, thank you very much. The Alliance, Australian Global Health Alliance, is really honoured to be part of this partnership. And I want to first, before I begin this session, acknowledge each of you in this room for the ongoing efforts that you've made in your work, TB, AIDS, and other health systems strengthening. It's really an inspiration to listen to, and I know that this has continued long before the pandemic, but now during this crisis, it's needed more than ever. So to those of you who support you, and to those of you who continue and to learn, and the next generation, really thank you. So I'm going to start by first introducing, I'm sure most of you know, Peter and Lady Rosalind, but we have today Peter Sands, Executive Director of the Global Fund for AIDS, TB, Malaria, and also Lady Rosalind Morata, who is the Vice Chair of the Board at the Global Fund and also on the Advisory Board of Pacific Friends Global Health. Welcome. I'd like to start, with the way we're going to run is simply just to have a few opening remarks and then we'll immediately go to Q&A. So I just want to start actually with Lady Rosalind. What has the era of the COVID pandemic, how has it affected TB efforts on the ground, and also what is the Global Fund planning strategically?
Thanks very much, Selena, and thank you to Global Health Alliance and Stop TB, Luchika, James, for organising this session. Great to see some new faces. I look forward to meeting you, and of course many familiar faces, especially my one talk there, Leslie. Great to see you. I want to make a few points on why a fully funded global fund is essential for the fight to end TB. We all know the impact that COVID had on the global TB response, reversing years of global progress. Deaths increased. The number of people treated for drug-resistant TB dropped by 19%. Treatment for people with extensively drug-resistant TB fell by 37%. Overall, the number of people treated for TB fell by 1 million. And this is a critical issue for our region, the Indo-Pacific region, which is home to 7 of the top 10 countries in the world of TB incidence. India, Indonesia, Philippines, Bangladesh, Pakistan, Myanmar, and Vietnam. Our region accounts for 53% of the global burden for TB. And COVID was acutely felt in the region. TB treatment coverage dropped by 47% in 2020. Case notification in the highest burden countries in Asia declined to 56% of incidence. So it's obvious what the effect of COVID had on TB programs. The second point is the persistent issue of underfunding for TB. We know it's the poor person's pandemic, and it attracts only a tiny fraction of the political energy and financial resources which, for example, were devoted to COVID, or indeed to most other diseases. Global Fund is by far the largest international funder of TB programs. We provide nearly 80% of total external funding for TB. We're helping countries try to reverse the setbacks from COVID and also to introduce new tools and diagnostics and treatments. In the last 6 years, we've more than tripled our investments to fight multi-drug resistant TB. But the third point I want to make is that we need to do much more. Last year, the board approved a bold plan to get back on track to eliminating HIV, TB and malaria. For TB, we plan to focus on finding and treating all people with drug-resistant and drug-sensitive TB through equitable, people-centered approaches. We want to scale up prevention, we want to improve the quality of services, and we want to adapt programming to respond to changes, including through rapid deployment of new tools and innovations. And really importantly for everybody here, we plan to promote enabling environments in collaboration with all of our partners and affected communities to reduce TB-related stigma, discrimination, human rights and gender-related barriers to care, and also to advance approaches to address the catastrophic costs of TB. But to implement all of these plans and to work with you at the scale required, we need a fully funded global fund. The seventh replenishment is crucial for TB. By achieving our target of $18 billion, at least $18 billion, which is a 30% increase on the last replenishment, we'll be able to increase TB funding by 40%. This would enable us to help to step up our support to the hardest hit communities and do all the other things that we want to do. At that point, I might hand over to Peter. And Selina, I think you've got some specific questions for Peter.
Thank you very much. Just to, maybe it would be good, Peter, to share what lessons the Global Fund has learned during this era of the pandemic and how it can be applied to TB efforts globally in the rest of your comments as well.
Thanks, Selina. And first of all, I agree with everything Lady Wells said. But what are the lessons we've learned from the COVID pandemic? Well, I think the first lesson is that when the world really wants to deal with a pandemic, extraordinary things can happen in terms of scientific development, resource mobilization, and political action. But it's got to want to, and it's got to think it's a pandemic, which I'm afraid tends to mean it's got to be threatening people living in rich countries. And that is the challenge we face with TB, is it's not even counted as a pandemic. And we have to change that. And that's, I like the phraseology, there's things wrong with it maybe, but of a poor person's pandemic, is to say, this is a pandemic, it's just you're not paying attention to it, because it's not the people who live next door to you or in your own house. If you're living in a rich country and influential and with power. But on any objective criteria, TB is a pandemic. And this is a source of inequity which, we've all talked about the inequities of providing medical countermeasures to fight a pandemic. We haven't really talked about the inequity of who gets to say what counts as a pandemic and who gets to say when it isn't a pandemic anymore. And we need to keep forcing TB into the discussions around what constitutes a pandemic. So that I think is the first thing, which is we've got to be on that agenda because that's a more powerful agenda and bigger things happen and they happen faster. The second issue, I think it's been raised in multiple times already, which is that when a pandemic hits, the hand you have in terms of the systems and capabilities and ability to respond is the one you've already got. You don't have time to suddenly upgrade your genomic sequencing and all this kind of stuff, or molecular diagnostics. It's what you've got. And for many low and middle income countries, what they had was largely what was in place for TB. TB was the distributed diagnostic capability for molecular diagnostics. And for many countries, that was absolutely vital to the COVID-19 response. So it does reinforce the case for using the fight against existing diseases, and TB is probably the most powerful example of this, but in rural areas you can argue it's also true of malaria. Using the fight against existing diseases to build the capabilities that allow you to detect and respond quickly to new threats as they emerge. So it's a point that's obviously been discussed, but it's again one we need to keep hammering home. Two other observations I would make as lessons we've learned. One is the advantage, the need for speed. I think we've come to normalize in the world of TB a sort of expectation that things don't happen that fast. When you get new regimens, it takes years to roll them out. Or when you get changes in policy, it takes years to get them done. We shouldn't accept that sense of everything takes years, because in the meantime, lots of people are dying. We should have a sense of urgency around when we have new tools, we get them into the hands and bodies of the people who need them as fast as possible. And when there are policy changes that can save large numbers of people's lives, we have that sense of urgency about getting them done. Because speed matters. And you know, TB is not a world known for its speed.
No, but also it's known for lack of money. Yeah.
No, absolutely, but it's, which is where you come to the first point around the way people are looking at the thing. But I'm not sure it's even, I mean, if I take bedaquiline as an example, there was a point where we were going around pushing countries to take on the new regimens, and we were saying, and we will pay for it all. So in that instance, it wasn't the money, it was inertia and reluctance to sort of shift quickly to new things. So money is absolutely a huge problem, but we also need to have that mindset of adopting new stuff. And then I think my last observation would be, and this is again about money, but it's also about mindset, is when you look at the speed with which granular, real-time information is generated on COVID, you know, so the health minister of Singapore can stand up and tell you what last week's mix of BA4 and BA5 is and all this sort of stuff. We operate in a kind of grey fog in the world of TB, right? In terms of how frequently and how granular the information is, and also the degree of specificity about the different strains of drug-resistant TB and what the trends are in terms of their emergence and incidence across different communities. The cycle time, the granularity, the degree to which we're using the latest tools to actually understand what's going on. And yes, Lucica, it's definitely about the money, but it's also, there's a kind of acceptance of things as they are, which I think we need to sort of get rid of and say, actually, we need to know, you know, in any high burden TB country, we want to know what was happening with TB last week.
Yes.
And we don't want to be talking about generalities of drug-resistant TB versus drug-sensitive. We want to know exactly what types of drug-resistant TB are we talking about, and what's, you know, how much of it is treatment-induced and how much of it is transmitted, and that we need to, if we're serious about dealing with all these things, we need that kind of level of specificity. So I mean, it does come back to money, and it comes back to kind of ambition as to what everybody involved in the fight against TB is really sort of setting out to do. On the money side, Ralston's made the point, if we're not successful in the global fund replenishment, well, we've got a hell of a problem. It is to put it on the negative side, because given that we are almost 80% of all the funding on the external side, and I would say it's particularly problematic given the pressures on, there's inevitably going to be acute pressures in many high-burden TB countries on domestic fiscal budgets, given all the pressures on food and energy and all that kind of stuff. We know that's the case. So we can't afford to fail on the replenishment. And then we also need to be seizing the high ground on this issue of, if we're going to talk about pandemics and we're not talking about TB, we're not having the right conversation. And actually, we will deepen global health inequities. If you want to simultaneously make the world safer from pandemics and attack global health inequities, you have to talk about TB.
Thanks. Thank you. Excellent answers. Shall we open the Q&A?
Can I just say something? It's actually in support to what Peter said on one point. Just because we had this, it's on the money and on the mentality. So it's absolutely true and correct what Peter said. First, on data, that unfortunately, if somebody here in the room, but not somebody here on the room, because we know that, journalists with whom I speak, or we all speak, and they ask and they say, okay, but what happened with TB last year? Or even more people say, well, it's June. You should tell what happened in March or in January 2022. The official data that we have, that we can all quote, are the data of 2020. And nobody can, I mean, like, you go now and you say, the latest I can tell you was like what happened in 2020. People immediately say, okay, go home. I mean, like, I don't care. Who cares? It's like I tell you, how was the weather last week? I'm not interested. I want to know how it's today, and I would like from what is that to know what happens tomorrow, to know how to prepare myself. The only country in the world having the best live data for TB is India. And now Modi is asking for a version 2, in which a lot of more variables will be included, but India is the model we have, and we push now, and thank you, Peter, for your team, to Stop TB Global Fund with WHO to try and do more live data for TB. But more than on the data is this mentality of new tools. What Peter said is correct. Countries are scared to scale up. Then we have a gene expert for 12 years in the world. Only 1 in 3 people diagnosed with TB are diagnosed using a rapid molecular test, even though it's recommended by WHO. The rest are diagnosed with smear microscopy. Still. Yeah. And it's the same. So there is a fear. Now, what I want to say is that the fear is coming, though, I'm trying to understand why. A lot of it comes from the fact that traditionally, the programs for TB were so underfunded that it became a self-limiting factor. The NTPs and the teams are afraid to ask for more. They know that the government will give them a little bit, then Global Fund puts a top up, and then they don't build in a priori to say, you know what, for all my people I want to have a rapid molecular diagnosis, everyone should have access to full package of care. Everyone is budgeting. Civil society and communities engagement, advocacy budget, MNE budget, communication budget, and so on. That's how you construct a comprehensive NSP. It's not happening. They put a certain percentage of people having that and that and that. So how do we go there in the blocking and not making all just about the availability of money, but even the mentality? The last point I want to make, the biggest and the most important thing that happened when Modi said, Prime Minister Modi of India said, let's end TB by 2025, was not only the importance globally, was the fact that then he had a team to speak and say, what does it mean to end TB by 2025? My goodness. Preventive treatment, okay, how do you reach people? What kind of money we need to go in the community to reach in India? So when they started constructing the budget, they almost fainted because it was more than 2 billion or something per year. But it helped because it made everyone think, wait a minute, we never constructed our national strategic plans with having in mind to end TB, to empower the community, how much it costs to empower the communities. But once you do a big push, maybe it costs initially, but then it's just like you said, Pakimran, you just continue to support that. So you don't need every year to construct, and you can have this for other diseases as well. But you see, the problem is that these discussions are, the NTP program is doing that by themselves. They are not necessarily discussing in a larger, in which they say, I build the communities now, but this will help HIV, this will help others, so let's push together in this and so on. So it's a broader conversation in which Global Fund, I think, is a very important partner to be able to change completely these mentalities at the country level and be sure that we get the funds needed. Thank you.
Thank you. Yes.
Thank you so much, both Lady Rose and Peter Sen. I fully agree with you concerning we need to see a big change, especially to push, to have tool, to have new regime on the ground. But importantly, I think that if there is not a strong movement from community to demand for those, I think that will never happen. So, for myself, I've been engaged in HIV in Cambodia since the early days. And I see that the strong movement from HIV, we can see a big change. Even in Cambodia, for example, we will end AIDS by 2025. So even we can say 5 years ahead to the global target. But for TB, in our current national strategy plan, 2021 to 2030, we still say 2030. But, let's come back to data. 21 data of screening of case notified even lower than 2020. So how can we go to that? Cambodia is still 274 per 100,000. We go to NTP unless Dr. Ruchika mentioned this morning, at least come to 10 cases, 10 people per 100,000. I think for Cambodia probably takes some time. And maybe not just Cambodia, most of the case in our region. So come back to funding. Fully agree with you, Lady Rose, that we need to see Global Fund is fully funded. But at the meantime, back to what Peter Sen mentioned, I think that we need to have a big move to make sure that the funding to community, funding for CRG, it's not just service delivery, but have a strong advocacy, strong movement of these people on the ground to push further, to have the new regimen be implemented. The example of Bedagilin, I think that this is really a good example. But Gen Expert, digital X-ray machine, for example, for us, we just got a new digital machine from X-ray machine from USAID to support our 10 district, underserved 10 district. So I think it's not just the tool alone, but we need to have the demand from community to say the tool already there, but we need to use it immediately. So without having that, I think probably it's still keep in the store and may not work well. So probably the funding that you just mentioned for TB, hopefully Global Fund should increase funding for community. Thank you.
Thank you. I should have said when you take the microphone to introduce who you are. And any more questions? That's Abby, and at the back.
Hi, I'm Abby Minter from Pacific Friends of Global Health and the Australian Global Health Alliance. And as global health advocates, one of the key challenges that we face every day is that funding needs are growing, particularly with the impact of COVID, but that the pool of money is continuing to shrink. In the previous session, Australia was really put on notice, but we know that that is happening across a number of key donor markets, such as the UK. And in the first session this morning at Health Ministers meeting, they were discussing the merits of a new pandemic financial intermediary fund, of which they mentioned there's already been about $1 billion in early commitments to. And so my question is, what are your reflections on building new mechanisms to fight infectious diseases and adding to that competition for that shrinking pool of money? And I think adding confusion as well to an already complex global health ecosystem when there are already proven organisations like the Global Fund who just could be better mobilised and resourced to achieve a number of those objectives of the fifth.
I didn't plan that question. So just tick
She answered it herself.
Yeah. Any comments? Reflection? No. Okay. Let's keep going.
I just actually wanted to comment on the question because I think one strategy that we should really be pushing for is to debunk the myth of shrinking resources. It's really shrinking political will.
Yep.
If the government, if donors wanted to invest in whatever priority they see as a priority, money would come out. We should remember the economic crisis like a few years back when governments wanted to actually salvage the banks. They did throw out money. So it's a myth that money is not there. There is money. It's a matter of political will.
Okay. At the back, yes. The lady's been waiting a long time also.
Hi, good afternoon. Rachel Ong, Global Fund Advocates Network Asia Pacific. I'm based in Singapore, and thank you all the presenters, all the speakers, specifically from the communities, for all your important work that you're doing in the country. I just want to emphasize a little bit from what Chamroon had said and what Abhi had said and RD had said around that it's not only just the shrinking political will, it's also a lot of the events that are happening. I think we're all quite shocked, or maybe not that shocked, with Roe versus Wade being overturned in the US. We're also very concerned about what's happening with Ukraine and Russia, which is actually, as Peter said, impacting global prices in terms of, so even if you do raise more money, everything else gets more expensive. So how are we dealing with the really important questions of some of the TRIPS discussions, for example, at the WTO? I just wanted to also follow on the very important thing that we need to make sure that there is going to be civil society in the governance of the fifth. So it's not just about the modalities of the fifth and the implementation and who gets the money, who spends the money, where it goes to. We need to make sure that there is no shrinking space or further shrinking space for civil society in these global health architecture institutions. I have something else to say about domestic resource mobilization, but I'm taking too much time.
Yes, lady in green, in the front. Oh, sorry, excuse me. Yeah.
Just Leslie Bola from Papua New Guinea, from the Key Population Advocacy Consortium. Just an observation with all the funding resources that come to Papua New Guinea. There's still, for me, we have lots of resources coming in, pouring into the country, but there's still lack of coordination. For me, from my observations from our partners who have been supporting us in Papua New Guinea. So what I'm emphasizing is we could have some mechanism where the partners or our partners at that level talk to each other, because at the end of the day we are saving the same community out there, and there's duplication, complications, our communities are confused. So at your level, if you could just emphasize on coordinating at the top level, so when it comes down to the grassroots level, our communities are not confused and all that, even our government. So that's only my observation from previous experiences. Thank you.
Okay, we'll take you and then we'll have a response.
I'm Ramya from REACH, an organization working closely with affected communities in India. So I think we were talking about this access. Ruchika was mentioning about how 1 in 3 people get access to rapid molecular test. And I think we still haven't created that critical mass. So we are still miles to go before we create that demand generation, and that's why investing in communities is very critical. And I think, I sit here coming from India, and sometimes it's a bit embarrassing because we have so much of resources, and but we are not able to glamorize this investment in communities. I mean, we have corporates willing to come and fund a machine and put their logo and their name, and that seems more glamorous. But we are not able to garner that kind of interest in communities. So, and these are the communities who are there finding local solutions. So they are able to garner resources from a local politician or their Panchayat Raj leader, tapping into that local resources, and Red Cross or a Lions Club, and able to actually help in bridging that last mile gap. So I think that is why we need people to invest in communities, so that the communities can take care of the people with TB. Because we cannot reach directly. I mean, like in India, the sheer numbers, anything we do, it seems like a drop in the ocean. So unless we build their capacity to take care of themselves, and it's going to have a far-reaching impact beyond TB, beyond COVID, for any public health challenge that we face.
Thank you. I think, unless it,
Should
maybe
we
say
start with
something.
those? Yeah.
I'll come out.
Oh.
Yeah.
Oh. That was sly. Can I start by the point about your debunking point on the financial resources? And I speak from a background as being a banker and economist, just to reinforce that point. In the COVID crisis, the rich countries didn't hesitate to put about 12 trillion available. They didn't talk about innovative finance. When governments start talking about innovative finance, it's normally code for we don't really want to spend money on this. And there is a role for innovative finance, but often it's a diversionary role. And so it is fundamentally about political will, as you said. Because also the other point is whenever you do any economic analysis of the returns to investing in TB, you come up with a ridiculous number. And then if you halve the number, it's still a ridiculous number. And so the any sort of rational analysis of it gets you to the point that you should step up in investment. So I do think that puts us in a position where we have to ask the question why it isn't happening. And what are the impediments to getting politicians to actually think it's in their interest to put their own names and careers on the line around stepping up the fight against TB. And that is something that is not going to be generalizable because the dynamics of that are going to be different in different countries. But when I think about Modi making it a kind of legacy project for him, what we need is other leaders in different countries to, I sort of sense that Pakuri is moving in that direction. And the more we can get him to see it as the thing he's going to deliver when he steps down is a massive change in TB, the more powerful that will be. And it does mean getting into the psychology of, I'm afraid it is, of individual leaders and sort of working out what makes them tick. And this is another aspect. I mean, you talked about the various crucial roles that communities play. You're on the ground. You will understand the political dynamics better than people sitting in Geneva are ever going to do so. But sometimes I think we're not calculating enough, because we might not necessarily all like these people that much. We might not share all their political views, but we have to work out how to get them in a place where they're going to deliver what we want them to deliver. And that means kind of being quite Machiavellian. But I think, together as a community, and particularly those of you on the ground in the communities, have to be prepared to do that, because I don't think there's I can't think of a single example where we have made massive progress against TB with a government that isn't interested. At some point or other, you need to get the government on board, because it's just too big a thing and requires too much infrastructure and so much breadth. And so that I think is one of the sort of central things here, if we're going to crack the political will problem. I can't even read my own writing there. I want to pick up on Rachel's point about some of the other sort of things going on, and particularly what's happening with food and energy prices. My view is we've kind of missed the point with some of this pandemic preparedness stuff, because having just suffered a new pathogen, we're all saying, what's the next new pathogen? And now we actually have a health crisis, a new health crisis, which is being triggered not by a new pathogen, but by food and energy. and the way it'll turn into a health crisis is it'll just make everybody more vulnerable to the same old diseases. We know that treatment success rates on TB are lower if people are poorly nourished. We know that child survival rates with malaria are lower if the child is poorly nourished. And I don't think we've yet got that narrative out there in a powerful enough way that actually what we're going to have to be doing, and we've already been doing it to some degree, and again it's a role that communities have a particular you have a particular role to play here. We've already been in a position where, with the very poorest people undergoing TB treatment, providing nutritional support, because if they can't eat, then they're not going to get better, or they're going to come off treatment because they need to earn enough to eat. My worry is that that need is going to scale up significantly, and that one of the key things is going to be identifying where it's going to be necessary to be, because that requires a level of granular understanding of people's situations in life that the formal health system is probably not going to have in many cases. In terms of well, I think the trips and all that sort of stuff, I think is a subset of the broader point of we've just got to squeeze the most out of every dollar we have, and whether that's in finding ways to challenge intellectual property, or making every things like bidirectional testing, so that when you've got a patient in front of them, you do as many things as possible, as opposed to going out separately to test them for different things. We absolutely need to promote competition and innovation in diagnostics. That would be the thing that would, if we could get lower cost, multiplexed, point of care, molecular diagnostics at a lower price point, that would be the really transformational thing for TB. The last point, I was struck by some of the I was just sort of reflecting on some of the conversation around the analogies with HIV. And in the HIV world, we've been using the 1990 cascade for many years, right? And we've sort of come to the conclusion that because of the dynamics of the heterogeneous nature of the population, in fact, if you want to get infection rates down, you sort of have to go to 95, 95, 95. 90, 90 isn't enough. And yet, here we are in the TB world, and we're sort of talking about getting excited if we get to 70. And everything we know about the dynamics of infection is, that's just not remotely enough. I mean, at 70 or even 80%, we're not going to see a significant decline in infection. And in fact, that's what we are seeing, is we're not seeing significant declines in infection. And again, it comes back to this ambition point, is we need to be working back from the point to say, what would have to be the case, both in terms of the way communities interact with the formal health sector, the way private sector providers are included, the kinds of technologies we deploy, to get us into a position where that 95% of the people infected with TB are diagnosed and treated. Because then you're really in a situation where you can get a grip on the disease. Yeah. But that is so far from where we are in most places that it requires a bit of that kind of mindset change, Lucia, that you were talking about.
Abby, your question about the fifth and Rachel's points about it, I think you answered the question yourself in your comments about it and the concerns.
Oh, we should all have our own mechanisms.
Yes.
More mechanisms, the better.
Yes, and reconstruct everything all over again.
Start from
Start from scratch.
Reinvent the wheel.
Go with new things, yes.
And have to make all the arguments about why governance bodies should be as they are, and to include communities in the global south and all of that.
Exactly.
So I'd say that's work in progress. But I just wanted to reinforce the point about demand and thinking big, ambitious, and the role of communities in all of this. The demand will come from people with TB. So how do we translate that? We've got to spell out exactly what it's going to take. I think, we're very good at just advocating for more money or more this or that, but we're not specific enough about what that money will do. And I think that's really important if we are going to get through to politicians. We need more money, but we need the political will. But what are we going to do with it, and what will that mean for people? And I think we've got to be much smarter in making the economic argument. As Peter said, it's obvious. But the fact is, if we just go on as we are now, with the same level of investment in TB, 28 million people will die between now and 2030. I mean, that's phenomenal. $1 invested in TB will bring $30 worth of economic gains. And if we just go on as we are now, the world economy, it will cost us $1 trillion. So, I mean, it's just obvious that we have to try to get this message across to the people who think, well, there's not enough money, or we just need to do things as usual. We can't do things as usual. We have to step up.
Well, thank you, Peter, Lady Ross, all of you for your time and trust this afternoon. I'll hand back to James for the concluding remarks.
Well, thank you very much, Peter, Ross, for your time. We know how busy your schedules are, and I know it's very much a visit looking at, getting increasing support for the next replenishment. I know everyone in this room is very, very astutely aware of that and looks forward to working with you to achieve that outcome, but also to, once we get to the 18 billion, seeing those increased investments that come with that for some of the things that everyone has spoken about at length today. I know a lot of the community partners also, spoke a lot about the importance of mechanisms like Challenge Facility for Civil Society that do those sorts of things about demand generation, Lady Ross, like you were speaking about. So I think that that's something that, is an opportunity to really sell and pitch that and see some of those, ideas going forward. But I think, Daniel, you had your hand up. I know you always like to have the last word. I know, Peter and Ross, you have to go to another meeting, so maybe just be very, very brief.
Oh yeah, thank you. Thank you, Peter. Thank you, James. Yes, Peter and Lady Ross, there are two things. First, we get the money, 18 billion USD. That we have to be, commitment should be on the table that fully funded for the communities is not in the discussion anymore. It should be a priority to implement that better. The second thing, what I'm thinking is actually HIV, TB, especially, not malaria, there are a lot of programs. It can be collaborating and integrating strongly in many parts of, in the country level, and in the PR level, in the implementation level, actually in the country level with the government money itself. It doesn't have to make it separate, but there is some reason also. Then the second thing, when the money is not enough, the 18 billion is not coming yet, the fully funded for community should be on the table also. Because we do understand and realize from the COVID, without community engagement, we never solve the COVID in many countries. And the government put more money for health right now. There are a lot of cost-effective analysis can be done. My organization is PR for 7 years. I know a lot of things that we can do cost-effective analysis, although we have 12, but we can put that money for 18. If we have 18 billion, actually that's money, it can be for the 24 billion, let's say. With the cost-effective analysis, we know which one we have to put as a priorities. Our bottleneck, a lot of in the political will, in the local thing, and in the field will relate with the CRT and other thing, and community engagement. And the last thing, we are talking about sustainability of the communities. Because this money, it will the grant will, not every country will get in the next 5 years or 10 years, but we have to prepare how about the sustainability for the communities in the future. Thank you.
Thanks, Daniel. And everyone, just a round of applause for Peter and Lady Rose.
We want to take a photo with you. Okay. And you get some red scarves.
We crank up the AC so that we wear the scarves.
I think if you want to do a photo, you have to be very quick. I know that they have another meeting to step to, so please gather around.
Let's do it quickly. Okay, quick. You want to take a photo? Let's go there.
Photo. Quick, join if you.